Hi, everybody. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility Center. And today I'm joined by my feisty and fabulous co-host and friends, Dr. Susan Hudson from the Texas Fertility Center
Hello, everyone.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas.
Hi guys.
How are y'all
How's
Hey,
doing?
guys. Well, here we are about the middle of the summer now, and I can't believe it's already time almost for the 4th of July. And so we were just chatting about a little bit about fireworks. And so, do you guys like to do fireworks? Do you not like to do fireworks? Are you in a location where it's legal or illegal or
How does that work where you all are?
So fireworks are they're legal enough to be sold in all of the random grocery store parking lots. Like
Oh, wow.
usually mid June or so, you start seeing the pop up tents where they have them on the side of the road and in the grocery store parking lots and things like that, which is pretty horrifying when you consider by that point Vegas is dry as a bone and people go out into the middle of the
oh,
desert to do it, which I guess is
seriously?
okay because if you set a fire in the middle of the desert, it's the middle of the desert. Like there's
There's nothing
there's
to burn.
well, it's not that there's nothing to burn because there's dry underbrush and stuff, but
There's lots to burn. Just
remarkably, it's not like in general, big fires and stuff don't happen based out of here. They
yeah.
happen in all the other Western states around us. So I guess that's good. I don't know. But people buy all these ones and then they set them off in the street. And sometimes
Mhm.
they'll get the really big ones that you expect to see from the coordinated shows. And so all on 4th of July night, in the nights leading up to, and usually a night or two afterwards, you hear these big booms going off from legit fireworks, not the dinky you can do at home.
Yeah.
And it's really kind of amazing that nobody like that there's not more fingers lost and appendages gone and things like that. Like my husband's in the PICU and his unit
Oh,
taking care of all the kids. Like there's
oh,
pretty much always at least a couple of burns around this time of
oh,
year.
that's
Wow.
too bad.
So in
Yeah.
Texas, we have very strict firework laws that are not very strictly observed. So the ones that are strictly observed are you can only buy fireworks 10 days of the year preceding New Year's Day and 10 days preceding, and I'm pretty sure it's 10 days preceding July 4th. You cannot purchase them nor drive them into a city limit. Okay.
Oh,
I mean, there's all these kind of things, but of course, people do them on the street just like this.
yeah.
But funny story, my brother-in-law and sister-in-law are, especially my sister-in-law, she is a bit of a pyromaniac. And I would call her that to her face, and she would be like, absolutely. They've actually done the train. They went up to Dallas one time and did this training. It's whatever training you have to get the very fancy ones. And
Uh-huh.
like they have this huge firework extravaganza, so I don't usually have to go anywhere except over there to their house to watch fireworks, but it's pretty hilarious.
So I feel totally spoiled because in Vegas, all the
You have
casinos set off
fireworks all the
fireworks.
time.
Yeah.
Yeah.
And well, we don't have them all the time, but like there's always a good show on both 4th of July and New Year's. And by good show, I mean like the casinos pour legit money
Yeah,
into them because
spectacular.
they're big attraction points for tourism in the town. And so um yeah, even the ones that go off in the neighborhood are legit.
Can,
So
can you see
my
those from your house by the mountains?
Yes, there's a park right behind our house, so we always go there. And I know, okay, this is the time I need to go. This is the place I need to stake out. This is a number of blankets that I need to get enough space. But the problem is they've started taking all the grass out. And so there's less places to sit because it's more on direct rocks.
mm,
And the crazy people setting off fireworks do it on those hills. And so we have gotten a little bit more hesitant to go out there because we don't want to die. Um,
so
and yeah.
so that's a wonderful lead into the story that I was going to tell about 4th of July. The house that
Yeah.
I've lived in for about 9 years. It's not actually in, well, it is in actually Davidson County, which is the county that Nashville's in, but a little bit in the burbs. And so the first year that we were here, we had some people at our house and we were outdoors and we were doing cookout and so we don't usually shoot fireworks, although I'm not necessarily opposed to them. But so I went back into my house and it was maybe 9 o'clock and it had just gotten really dark and our friends had just left and I was doing something on the computer and all of a sudden I heard boom, 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 boom. And I'm like, I mean, for a second, I'm like, I felt like I was being attacked, like I was in World War II and like somebody was dropping a bomb. So I went outside, and so there's a country club that's about a half a mile down the road from us. And so come to find out, we have the most beautiful view of their country club fireworks that you could ever
Oh,
imagine. So we just have to stand out kind of in front of our house. We have some trees that block it a little bit, but I mean, they put on like a 30-minute, like beautiful fireworks show. And it's just right there for us to look at in our front yard. So it's really pretty cool. But the
that's
first year
awesome.
was terrifying because I'm like, what is going on here? So
I always
so you
find
guys
it
need to
interesting when people are like, I hear gunshots, so I walk outside of my home.
Well, it was so terrifying though. It was like, did somebody have a car act? I mean, it was like these crashing noises, but it just kept going off. And then suddenly it kind of hit me. It's 4th of July. And I'm like, who would be shooting? I'm like, oh, the country club across the street. And sure enough.
That's funny.
So so today we're going to talk about things that nobody tells you about IVF.
But we're
Do you
going to
have
do a
any
couple
questions?
questions first.
Oh, but we're going to do a question first. How do I keep forgetting questions? I always like to jump right in. All right, sorry. We're going to do a question first.
Okay, so our question is, hi, thank you for the great information your podcast provides. I'm 36 and had a stillbirth at 22 weeks in the past. Suffered subfertility since, so they did a round of IVF. They got 4 day 5 embryos out of 10 eggs, AMH of 20. One was mosaic. Fresh transfer was successful, but had a miscarriage at 15 weeks.
Oh.
We have since done 2 frozen cycles that failed. My GP discovered that my DHEA is only 1.1 there in Australia. So she thinks they'll be affecting the entire cycle, even though they are regular in 26 days. Fertility specialist says nothing's wrong with my hormones, but why would a fresh cycle work and frozens fail? What are your thoughts on DQ alpha match? I have a positive ANA, celiac, plus autoimmunity in the family.
Well, I think we've talked about autoimmunity in the past, and the really tricky part is we just don't understand a lot about the immune system and reproduction. We could take your husband's kidney and transplant it in you, and you have to be on all these immunosuppressive drugs, whereas we can take an embryo and put it in you that's half from your husband and half from you, and we don't need to do anything. So I think all of the ideas that you've listed are not necessarily things that we know from randomized prospective studies. It doesn't mean that any of them are wrong, but I don't think there's really good data to show that, matching of HLAs and things like that really make a difference. Those are kind of concepts that were a thing probably 15 or 20 years ago. And I think those have kind of fallen by the wayside. It's hard to know why your 2 frozen cycles did not work. Unfortunately, we say this a lot. We can do the same thing over and over again and get different results. I mean, you were successful with that 1 15-week cycle, but I'm not sure that the immune system part has a big role in it. But honestly, I don't know. We don't have data to really look at that and know what the right answer is. What are
I
your
would say
thoughts, Carrie or Susan?
I would say make sure your celiac is under good control. Make sure you don't have anything else going on like Graves or Hashimoto's and all those kinds of things. But the thing that actually makes me the most concerned is I would probably recommend having a hysteroscopy at this point. You've had a 22-week loss and then you've had a 15-week loss. And the chances of you having something residual in the uterus from those, plus having 2 failed cycles, makes me very suspicious that the inside of the uterus may need to get tweaked. I think we would all rest more reassured knowing that all the housekeeping has been done and we have a great little place for that next embryo to kind of nestle in to develop over the next 9 months.
Mm-hmm. The DHEA levels themselves are something that, especially when we're doing frozen embryo transfers, but even fresh transfers, like we are controlling the hormonal environment so much that it doesn't matter if as many of those precursors are as precisely regulated as they might otherwise need to be, just because we're filling in the gaps. I mean, we're very conscious about you need this and you need this and you need this. And so this is how you're going to get each one of those things. And so that's something to kind of think about. And certainly having high androgen levels, which DHEA is a version of an androgen, so one of the male hormones, is really pretty common in a lot of patients, particularly PCOS patients. And they don't necessarily have like a guaranteed increase in miscarriage rate, particularly in those second trimester or later miscarriages like you're talking about. So I would definitely have all of the pregnancy loss labs done. My guess is you've already had most of them done just because of your history. Do the hysteroscopy, make sure your immunologic, everything is under tight control with celiac, with anything you do know definitively.
I wouldn't
And
worry too much about that ANA. Very non-specific.
yeah, I mean the ANA and the celiac, like I would pay more attention to the celiac because that's probably why the ANA is higher. But pay attention to your thyroid and some of the other big triggers, your blood sugars, make sure that all of that is well behaved. You know, the differences between fresh and frozen. Fresh is usually a very different environment than frozen, but you also have put the embryo through less. And so while we typically don't think that that has a really appreciable negative impact on the embryo, rules are made to be broken. And so it's entirely possible that for you, that happened to be not only the better embryo, but the best embryo that wasn't tinkered with either.
Mm-hmm.
So.
All right.
Any other thoughts or questions? Other
Questions, concerns, or funny jokes?
I think we're good to go on with the show.
All right, on with the show. So, so as I was saying before, we're going to talk about things that nobody knows about before, during, and after they do IVF. So, Carrie, you want to start us off and tell us one little snippet that you know that maybe nobody else talks about?
So part of the reason why we came up with this particular topic is a lot of our topics are chosen by really what we have all collectively heard in the prior week or two in clinic. And so I feel like the theme of my last week or so is nobody talks about this. And so one of the things that brought it up in this particular week was the emotional stuff that comes along with IVF, because everybody asks us, you know, am I going to be a crazy person during IVF? Because of course your hormones are all affected. They're higher, they're lower, they're whatever. And so the answer to that question is yes, no, maybe, and I don't know. And the reason it's so broad is because it really impacts everyone differently, which is a completely useless answer for everybody. But when you look at how these hormones interplay, so your estrogen is going to be higher during the course of an IVF cycle. Your progesterone will go higher. The progesterone may or may not be a whole lot higher than what it does naturally during an ovulatory cycle, so that may or may not contribute. Your estrogen, hopefully you're responding, so really hopefully that is quite a lot higher. And some people feel absolutely amazing. They feel really balanced. They feel like this is the best I've felt. Other people feel like they're hell on wheels and that they're snapping at their significant others and everyone else in their life like it's their job. And then people fall in the middle. And what I have noticed is I kind of feel like it's how you feel when you're drunk. Because you know how when you're intoxicated, more of your normal
No, Carrie,
personality.
I don't know anything about that.
They're laughing at me because for our listeners, because at the last meeting where we were all together, I had, I don't know, 2 drinks because I'm a lightweight and I get really chatty and talkative, which is not my normal MO. And
Yeah, no, she's not
really,
chatty or
it was
talkative
really
at all.
funny. It was really funny though.
Yeah. So, but I feel like the hormones are kind of the same. Like they just bring out more of who you are. And so a lot of people are running super anxious during this time period, which is very understandable. And so sometimes I feel like it brings out that anxiety.
I also think that it has to do with how you kind of manage yourself in times of acute stress. Okay. So we're all under chronic stress. Like we all have work stress, we all have family stress, we all have those things, but then you have those life events, and some people deal with those life events perhaps better than others.
Right.
And so if you tend to have a larger reaction to, you know, random life event as compared to maybe, you know, somebody else, this is one of those life events. And I think people don't go into this understanding that. You know, you think of it like losing a job or having a miscarriage or something like this, but so much of your hopes and dreams are on this that
Yeah.
you're not necessarily the same rational person. And so I think that plays a major factor in how, your just filter is a little bit less.
I think that's a great point. I think for me personally, because I was in the same shoes, I didn't have a baby, and I wanted to do IVF, and just like everybody else, I was really under stress. And I remember feeling anxiety, but I was able to work okay. And actually, I really think I felt okay on the medicine. It didn't really bother me that much. And I think we see that too when we see women that are egg donors. Women that are egg donors are going through retrieval for somebody else. It's not really their child that they're going to have from this. And so egg donors typically skate right through and usually do pretty well overall emotionally. But I do think Susan's exactly right. I never really thought about it as one of those big stressors on the life scale, like a marriage and divorce and job. But really, honestly, that in my life, that was a big turning point for me, So
Right.
I never really thought about it that way. But I think you're exactly right. I think there's so much that's, that's going to be changed by this, good or bad. It's a big deal. It's
And
emotionally stressful.
there's little things that tend to be your triggers. Like one of my triggers is I really don't like it when I'm told one thing and then I'm told something else. And it's like, well, were you wrong? Did you lie to me? Like where did the communication thing fall? And I mean, I remember like this one particular day, like it was yesterday and it was 14 years ago. And the clinic that I was using had told me one thing about my PGT testing. And then they're like, oh no, this isn't exactly how it works. This is what's going to happen. And I literally just got off the phone with my nurse and cried because I couldn't process what was happening. And I would have normally been able to do that.
One thing that I think a lot of people get caught off guard by is a lot of our patients are very meticulous, high achieving, smart individuals. And so they go through the immediate stress of IVF really pretty well because
They're
they're in
methodical.
make it work mode. And then you hit one of the waiting points. So you go through the cycle, you trigger, you retrieve, and then you're waiting. And that's when they break down and fall apart. And that's when they start to see, I'm flipping out because my coffee is 2 degrees warmer than I wanted it to be, or I asked for 3 ice cubes when they only gave me 2, or whatever it may be. That's when they flip out. And it's because the immediate stress that was not life-threatening, but on that level, is gone. And so now they have the comfort to relax and react to it. And it seems like, what the hell is going on? I'm not in the middle of this. Why am I like this now? And it's because you've relaxed enough so that you can actually have that reaction and have that response, because now there's not nearly as much at stake because you're just waiting.
And the other part of it, which really even before the IVF cycle starts, some people get really stressed and anxious about this, is a lot of us, the way we relieve stress is exercise. And so now we've taken exercise and sex, two different ways to relax away from you. And so a lot of people are really worried about how they're going to cope when they can't exercise. And generally, that's for the 2 weeks, at least the 2 weeks leading up to the retrieval, and usually for the 2 weeks after. Because, and the medical reason we ask you not to do those things is because your ovaries are really large and they're attached by a blood vessel. And if the ovary is really large and gets bounced around, it can twist that vessel and basically cause it to block and result in a torsion. And so it's not that we're trying to be mean, but that we're doing it for a medical reason, but that also plays a role as well.
Carrie.
To be clear, we don't want you to have sex, but I don't think anybody has got an objection to you having an orgasm, so long as you're not doing anything that's gonna twist those
Jostle.
ovaries or make them bleed or anything like that. So we don't really want anything in there. We don't want any toys. If you've got a good vibrator, have at it.
Another thing to think about is when you're going through this process, another thing that people don't know, a lot of times people are on different blogs and internet sites and things like this, and they're comparing what one clinic does versus what's
Yes.
happening to them. And I love the saying that there is an art to art, assisted reproductive technologies, and it's very, very true. And so we all have, although the three of us practice very similar medicine in the grand scheme, there's things that we all do that are different, and that's okay. Okay, there is not a set in stone right way to do it. And even between, if my patient A and my patient B both have PCOS and male factor, there's still going to be something in there that's going to probably make me not do exactly the same thing between the two of them at some point during their IVF cycle. And that's actually the beauty of it, is these things are very tailor made to your particular situation. And so, like, understanding that there is not an absolute right or wrong way to do something is also something that I find a lot of people
Yeah.
find unexpectedly.
So, Carrie, the other thing I think that makes people, and I know for me personally, it made me a little like, angry, is all the poking and probing. And I think nobody understands until they do it how many shots you get, how many times somebody's poking a vaginal probe in your vagina, they're sticking you and drawing blood. And so, what are some things that you've learned from patients about that you would give as advice?
So a lot of people fear the idea of it more than they actually fear the action. And I would say that this is very, very true, because people, they know that they're going to have to give themselves injections. Most people come into IVF knowing that that's on the table. And especially when you describe, like when we're going through the prep appointment of, okay, you're going to give yourself injections every day for about 2 weeks, then we're going to have you take the special trigger shot at this very specific time, blah, blah, blah. They hear all that and their brain goes into panic mode because, oh my God, I hate needles. I don't want to do this. I can't do this. I can't do this on myself. What if my significant other's not home? And so they can't give it to me and I don't have any friends at home and da 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 da. And what they find is that, number one, you are a smart enough human being that you've made it this far in life. I guarantee you, you can take a needle and poke it in yourself. Like there's not a doubt in my mind that you are smart enough, competent enough, and able to do that. But I think people psych themselves up about it. And so to a degree, once you just decide, okay, we're going to do this, you just say, all right, this is what we're going to do, in the same way that maybe the first time you put on a pair of sneakers, they're not super comfortable, but by the 10th time you've done it, you're like, oh yeah, this is okay. I'm fine with this now. Like you settle into it. And every time you do something uncomfortable in your life, whether it's starting to work out or a new job, the beginning of it is uncomfortable. And by the time you get a week or two in, you're kind of like, okay, yeah, I can do this. And so I think people psych themselves out a whole hell of a lot more than they need to about the thought of needles, because it is much easier to focus on that than it is to focus on, oh my God, if this doesn't work, I'm not going to have a child.
Well, and in full disclosure, I would add in, just if you are one of those people that freak out with needles, you're probably going to be getting more than one injection a day. And it may start out with you only being on one injection, but then as you go further in the cycle, as your ovaries get bigger and your eggs get bigger, a lot of times there's a second injection we start, and depending on the amount of medicine that you're on, sometimes we have to divide it into a morning dose and an evening dose. So sometimes there's more than one injection, and just Carrie gave great advice. Just I think you just sort of have to tell yourself, okay, I'm going to do this and I can do it. And it's a little tricky when you start to stick yourself, even as a physician, when you start to stick yourself at the beginning, it's kind of like, I don't know if I can do this or not. And by the time by about the third or fourth injection, you're like, I'm
First
cooking
one's the
dinner.
worst. The first one's the worst. And then you're like,
Yeah,
no, this is
it
what
gets
I was
better.
all. And if you're really nervous, talk to your clinic. They always have pointers, whether it's ice or
Mhm.
numbing gel
Or
or,
Emila
you know,
cream, yeah.
yeah, like
Yeah.
there's all kinds of things. I mean, some people need them, some people don't. Okay. And we do what we need to do. And I mean, when it comes to, these injections and stuff like that, we were kind of talking about a lot of us being control freaks, and like, control the things that you can.
And you
Okay.
can control that. You can control when you give the injections,
You
kind
can
of, and
control when, like, what, during which of that window can you do it. I mean, I remember sitting there with all my stuff laid out in a bathroom in a Chinese restaurant in New York, and I had like everything lined up, and people are walking in, and I'm like, don't mind me. You do what you need to do, but like, let yourself do it. I mean, that's a big thing. Like, have faith in yourself.
Another thing about the injections that nobody talks about, sometimes you can bruise, sometimes you
Mhm.
can bleed. Both of those things are normal, and it is very unusual that they're anything to worry about. Because when you're going in for these injections, a lot of the times they are sub-Q, meaning subcutaneous or just under the surface. And so it's very easy to hit a tiny little blood vessel. And everybody can tell you, every surgeon that you come across can tell you, oh yeah, it's the tiny little bleeders that cause the most distress, because they just go and they look super dramatic and it looks terrible and horrible and awful and oh my God, what did I do? And in reality, it's like maybe a teaspoon's worth of blood, but it turns colors and it goes yellow, purple, green, all of the bruise shades, and it can look scary when in fact it's just a, yeah, you probably hit a tiny blood vessel, it'll go away. Similarly, if you poke yourself and you get a little bit of blood or a little bit of fluid that's kicking back, it's fine,
Mhm.
Yeah.
because in general, that amount of blood is not something that's going to cause any harm at all, because it is such a minimal amount, no matter how dramatic it looks. And number two, the fluid that's coming back out it's pretty minimal. It's much less than you think it is. And the actual amount of medication that may not be absorbed is probably negligible. And most of us are giving with enough, giving doses and medications with enough wiggle room so that if you miss something here and there, you're probably going to be fine, because we build human error into a lot of what we do. And so, we got your back here. Like, we know nothing is going to go perfectly, and that's okay. We help prepare for that without necessarily telling you that we're doing it, so that we've got wiggle room.
And most of you will be on those lovely intramuscular progesterone shots. And everybody universally always complains about the lumps in their bottom from the
They're
progesterone
normal
shots.
and they will
They're
eventually go away.
Yeah, and that's the key thing. They itch too. So anytime your skin is kind of stretched out, it itches. And so a lot of people are really concerned that they have an allergic reaction, and some do, in fact. There's different medicines or different oils that you can mix with the progesterone. So some people are allergic to sesame oil, and some people are allergic to other ones, or canola oil or whatever. And so sometimes it truly is an allergic reaction. But as long as you don't see a rash or anything like that, it's not an allergic reaction. But definitely those spots cause itching, and they continue to itch for quite some time. And it takes several months for those lumps to go away. But like Susan said, they eventually do go away.
Since we're talking about itching, if you're taking Menopur, itching when you take your
Yes.
Menopur injection and a little redness that goes away after an hour or so, very, very normal.
Yeah.
Mm-hmm.
Um, when, particularly with the progesterone, oftentimes you see a red spot around it. And we were mentioning, look for a rash, look for that to help determine if you're having a reaction. It's pretty normal to see a red area around where the progesterone is going in, particularly if you're, a week or two in, like you've been doing multiple. It won't necessarily show up immediately, but after you've been doing them for a while, you may notice that. If it is problematic, itchy, painful, really warm to the touch, those are the things that we worry about, and just kind of
Yeah.
keep an eye on the redness, because odds are it's probably the normal redness. But if you're having any of these other symptoms with it, just have somebody at your clinic take a look at it, because we're pretty good about spotting, yeah, that's a normal reaction, or no, let's get some antibiotics for a little bit of cellulitis there.
So another thing that we often don't talk about because we kind of take it for granted is that as you go through your stimulation, especially when you're in kind of your home stretch in the last 3 to 4 days of your stimulation, like it's going to be uncomfortable. Okay. So, I mean, people are like,
Good
oh,
point.
I can't like wear my normal pants
Mhm.
and it just feels like there's so much going on in my belly and stuff like that. It's because it is. There is a lot going on. I mean,
That's
if you
right.
think if you think about it, the average size of a woman's ovary in their reproductive years is the size of one or two large follicles at the time you get triggered. And that's one or two. And you may have 5, 10, 20. It just depends on what your ovaries are capable of. But like, something that is normally that small, you're going to, I mean, the fact that you were able to change kind of the shape and structure of your ovaries in the course of 10 to 14 days, like you're going to feel it. And it's normal to be, you should not be in drastic dying pain. Okay. But if you're like, oh, this is uncomfortable. I don't like sitting here. It's just not not feeling great, that's okay. That's okay. And it will get better. It will get better.
The other thing that people don't necessarily talk about, especially as you hit the end of your stim, is when you give the trigger, oftentimes people start to feel pain and twinging either that night or especially the next day. Sometimes it's the morning of retrieval. So it can be in any of that time. But as those eggs are starting to release, there are some women who really feel that. And I don't know that it's really terrible pain, but it's surprising pain. And so that makes it scarier than perhaps it would be if you knew that it was coming. So know that that's very commonly occurring.
So one other thing I was going to add in before we move on after the retrieval, how important is it if, say, somebody gives their FSA shot like an hour or two late versus how important it is if you give the trigger shot an hour or two late?
Trigger shot, huge deal. Huge, huge, huge. If you, for some reason that doesn't happen exactly when it was supposed to, call your clinic, let them
Yeah.
know so that they can adjust things.
Yeah.
You know, if you do your trigger shot at night and you end up not doing it at the time that you were supposed to, first thing in the morning, give them a call. When it comes to your gonadotropins, your follistim, your gonal F, your menopur, those types of things, those you have definitely some grace period.
Yeah.
I thought of one that we hear all the time, the dreaded cervical mucus.
Oh.
Ooh.
Okay.
Bum, bum,
Ooh.
Bum, bum, bum.
bum.
Okay, so here is the truth. So correlation and causation, not the same things. And what I'm meaning by this is when you are going through your stimulation, your estrogen level is rising. High estrogen levels are actually the cause of that cervical mucus formation. Now, normally when you're going through your regular cycle, that high estrogen level happens right around the time of ovulation. But just because you have cervical mucus does not mean you're ovulating in your IVF cycle. So, not that ovulation is impossible, but is highly, highly, highly unlikely.
And the corollary to that, the other thing that people worry about is maybe they're day 13 in their IVF cycle and they say, I always ovulate on day 10. You know, I have already ovulated. No, you probably haven't, because we give you meds to stop that because we are meticulous about that. And so that's something to know as well. Like just because that's what happens during your normal cycle doesn't mean that that's what's going to happen during your IVF cycle because of the meds that we're using. Similarly with your period, we oftentimes have your period thrown off as well from what we're doing, especially when you have women who have, let's say, PCOS and they never have periods reliably or on their own. When we give you all the medications for IVF, we are making sure that you ovulate, which means usually a week or two later, you are going to have a period, even though you may otherwise have one period a year. And we know that. So when we're kind of nonchalant about it, especially with that first one, it's because we know it's coming. The one after that may not come, but that first one usually does.
The other corollary to kind of what you were saying, Carrie, is, our whole objective with your cycle is we want to push you as far as we can because we want to get as many eggs as we can. The more eggs that we get, the better your chances are. And so every now and then I'll have a patient that will come in on the weekends, and most physicians, with some exception, don't cover, 7 days a week in their office. So if you come in on the weekend, you may have your monitoring visit, and we may leave a message for you, or our nurse may call you and go, oh gosh, even though we thought your egg was going to be ready today, we're probably going to go another day or two. And a lot of times that really just at the end, just kind of like you said, Susan, before, it just kind of sets people off. They're like, what? I thought I was getting my retrieval today. I have everything planned to be off work in 2 days. Well, remember, the goal is we're trying to get as many eggs as we can. And we don't have a crystal ball, nor do you. And we don't kind of know what's going to happen with your ovaries. And so the end point is we want a bunch of eggs. And if we think we can push you another day and maybe get a few more eggs, that's what we want to do. And so sometimes people kind of have it in their mind, like when they're going to have their egg retrieval. And if it's different than that, they just really kind of come unglued sometimes.
Time of day is an important point of that as well. I have a lot of people who say, well, I need to do XYZ in the morning, especially, and our physician patients are super guilty of this. I need to go round in the morning. Can I do this in the afternoon? And unfortunately, no. And the reason for that is because there's a timeline that happens with all of this. So just because you get the eggs out at 8 a.m. doesn't mean that all of the work is done by 9 or 9:30. They usually have not even started on insemination until, close to noon. And when we get some of these cases that are really big with a lot of eggs, that insemination takes a long time. It can take a long time to find sperm. It can take a long time to do all of that. The lab is working around biopsies and other things that they have to do, because once these timelines are set in place, there's really only so much play. And so most of us are not going to do a retrieval in the afternoon, because that means that our embryologists are going to be there at 7 p.m.
Midnight.
or later, and that's not good for them. That's not good for your eggs. That's not good for your outcomes. And so we will try and be flexible when we can, but for the most part, it's going to be, no, you are going through a hell of a lot to get here. Let's optimize everything we can, and this is how we're going to do it. So.
Okay, so anything pre-egg retrieval that we need to talk about that we forgot to mention? Because otherwise we'll switch gears and talk about post-egg retrieval.
I think we did a good job on pre.
All right, very good. So, okay, so Susan, tell me a tidbit about post-egg retrieval that people should be aware of that maybe they don't know.
You are not going to feel normal for a few days.
Or a few weeks.
Because people think that you go into your egg retrieval, we suck out all that fluid, and your ovaries magically go down to like a very small organ. And that's not the case. Quite honestly, yes, we suck the fluid out, and depending on the type of trigger, if you do a Lupron only trigger versus a Lupron plus HCG or just HCG trigger, those are all going to have different time courses on how quickly the ovary gets back down to its normal size. But it is, and if you're somebody who gets lots of eggs retrieved, you are probably going to be more uncomfortable after egg retrieval than somebody who goes and gets 7 eggs retrieved. It's just, you've had more things done. And so giving yourself the grace to understand and recover and let your body get it again, it will get back to normal. But it just takes a little time.
I tell every patient when I go in to do their egg retrieval, and I try and tell all my patients this: don't go back to work the next day. Work can survive an extra day without you. I always say, if your ovaries are really large, sometimes we say, to use a food analogy, they're the size of limes. And some people that really get stimulated, your ovary may be the size of a grapefruit, and you have 2 of them, and they're pushing everything out of the way in your abdomen. And so your ovaries are rubbing in locations they're not normally located in. And so I always say, if you go back to work the next day, it's like putting your size 8 foot in a size 5 shoe and trying to walk around. Your feet are going to hurt at the end of the day. Your ovaries are going to hurt at the end of the day. And, just give yourself a break. Most people don't feel great the day after any kind of surgery. So I would definitely take the day after surgery off, just to recover and give yourself time.
I think if you can do that, that's great. But for those of you whose work or something doesn't permit that to happen, it's also not the end of the world. You do need to take it easier. But as somebody who had no maternity leave and I was doing IVF, and I was like, every day I'm away from doing this is potentially a day that I'm not going to be able to spend with my baby, that was a personal decision in how I managed it. But the bigger your ovaries are, the more likely you're going to need a little extra time.
Yeah, and I'd say we'll get more phone calls from people who go to work the next day as opposed to people who stay home. Because I think when you go to work too, you just tend to do more. You're just like, oh, I'm fine. I don't have a scar on my abdomen. I'm fine. So, but I do think it's a personal decision. But that would be my advice. I would say stay home if it were me.
So one thing post retrieval, everything comes down to poo. And
Yes.
there is a Scrubs episode. They did a musical episode where one of the songs that the 2 guys sing is "Everything Comes Down to Poo." And so if you need a laugh, go ahead and listen to that. But people underestimate just how uncomfortable not being able to go can make you. And when your progesterone rises at the end of the retrieval post trigger, that will slow down the motility of your gut. And so it will not cause harm, but it will sure as hell be uncomfortable, because if you can't poop, you've got all of that space and that real estate that's being taken up by that, in addition to your ovaries that are bigger than usual, in addition to there's a little bit of fluid in there. And so it can make people really not feel good. And so the second you notice things slowing down, start your prunes or your prune juice, your Colace, your Miralax, drinking fluids, going for walks. things that keep your guts moving so that you don't have to play catch up, because again, it's not going to harm you, but it is not going to enhance your life experience either.
Well, and how many of you have had visits to the doctor with people with severe abdominal pain, and you kind of do the whole workup and you're like, I mean, everything seems normal. One time early in my career, I even sent a patient over to the hospital because she was having such severe abdominal pain. She got a CT scan, and the ER doctor called me back and said, she's constipated.
It
So
happens.
it
It does.
happens.
It does.
Yeah.
So Carrie made me think when you were talking about there being some fluid in your pelvis. So everybody's going to have a little bit of bleeding from their ovaries. That is normal. We expect that. So with that being said, if you're having any complications, call your doctor's office. There will be somebody on call if you are going to the emergency room. Okay.
Mhm.
Because emergency room doctors, if you show up with giant ovaries and some
We'll
blood
freak out.
in your pelvis, they are 100% of the time going to freak out. It goes much, much more smoothly if
If you
somebody can
prepare.
call them and be like, hey, listen, they just had an egg retrieval. You should expect, if you do something to scan them, expect to see large ovaries. She's going to have some fluid in her pelvis. Like these are, yes, it's not quote normal because that's not what everybody else has, but it is normal for your situation. And so
Mhm.
having your doctor or your doctor's coworker explain this to the ER doctor that you are going to go see, it will make your life a lot easier.
And the
Well, and I'll
ED
say,
docs really appreciate it when we call ahead,
they
because
do.
it means we can usually streamline and say, get the ultrasound. This is what you're going to see. If you see this and this and this is what you're worried about. And if
Yeah.
you see this and this and this, that's fine and don't sweat it. And these are what labs you're going to see, particularly with positive pregnancy tests, because they will freak out about that. And if you've got an HCG trigger, you're going to have a positive pregnancy test. And so please let us help you in that, and call the after hours line, because we will run interference in that, and we will make everybody's life a little bit easier when it comes to that particular ER visit.
Well, and on the flip side too, things to call about. So if you're feeling really dizzy, if you're feeling really nauseated, you're vomiting, you have fevers, those are things that, and really in the first 24 hours, the thing, quite frankly, we worry most about is bleeding. Most people do bleed some, but generally your platelets do a really good job of stopping your bleeding. But every now and then crazy things happen. And so if you're really dizzy and things like that, you need to call, and probably a good idea to call your doctor first, unless you just are so worried that so, life threatening, you have to call the ambulance. Sometimes I've had patients that have called me and they've already, I'll give them some advice and I'll say, well, maybe just watch this a little bit longer. Maybe this is not real significant. They're like, oh, I'm already here in the ER. So it's probably better to go ahead and call your doctor first and really make sure that that's something you really need to do. Because there are definitely times when we'll say, absolutely go to the emergency room. And there's other times we'll say, well, this is probably pretty normal. Let's give it a little more time and see what happens and then go from there.
And if we're concerned enough that we tell you to go to the emergency room, go to the
Go.
emergency room.
That's the flip side. Yeah.
Flip side.
Yeah, I mean, like we want to keep you out of the emergency room, but there are definitely, I mean, we don't have a lot of emergencies in our practice, but there are a few, and our number one job is to keep you safe. So if we're worried enough that we actually say go to the ER, go to the ER.
Yeah. The other thing
Absolutely.
too, that is just a tiny piddly little thing, but especially as you're hitting the end of your stim cycle, consider sleeping with a couple extra pillows behind you so that your head is higher. That will keep any fluid that's starting to come out. And this is most relevant like right after trigger and in the days following retrieval, but it'll keep the fluid down where it's going to be anyway, because again, not going to cause harm if it goes up, but every so often it'll creep up and it'll irritate right under your diaphragm, and it'll send shooting pains up to your shoulder, which I've had one or two patients think that they were having heart attacks because of that. And it wasn't, it was just they had some fluid that hit just the right spot to irritate. And so if we can prevent that, so much the better.
So one of the side effects that we used to see a lot more commonly than we do now is ovarian hyperstimulation syndrome. And to a certain degree, everybody's hyperstimulated. I mean, most people ovulate one ovary per month.
Mhm.
And if you have 10 or 12 eggs, you're hyperstimulated. So it's really more severe hyperstimulation that we worry about. So kind of back to what I was saying about ER things to call for. And these are typically things that usually happen a few days to a week or so, or within that first week, I guess I would say after the egg retrieval, if they're going to happen. So if you're really short of breath, If you have really significant bloating, like your abdomen's tight and like, you feel like you can't even put your pants on. And
Pain or
sometimes
swelling in your leg.
yeah, sometimes we'll have you measure your abdominal circumference and see how different it is from maybe when you were prior to egg retrieval. If you have nausea and vomiting, don't think it's a GI bug, call us first, because sometimes that's one of the symptoms of a lot of pressure in your abdomen. It presses on your stomach and you can't keep your food down. So shortness of breath, nausea, vomiting, really severe pain. Those are reasons to call within the first 7 days after egg retrieval, because we worry you could be having hyperstimulation syndromes. Most of the time now we trigger you with a medicine called Lupron, and it really shuts that down. It's really, really rare for a patient now to get that severely affected by hyperstimulation syndrome. But if you have those symptoms, call your doctor's office and they can kind of help you again decide if you need to go to the emergency room or if it's something that can be managed at home for a little while longer.
And that period after your egg retrieval that happens usually between 5 to 10 days after your egg retrieval, it can be a doozy, especially for people who normally have light periods or are PCO patients who aren't used to having a period. Like, just be aware, you just had a lot of estrogen, and that estrogen did beautiful things to your uterus. And so don't be caught unaware.
Yeah, it can be a barn burner. Absolutely.
Yeah. Ibuprofen and heavy pads.
Yep.
So, any other tips that we need to tell everybody about before, during, or after IVF?
Not until we end this recording, and then all three of us are going to come up with 25 other things that we're like, oh, we should have said this and that and the other thing. Like, guaranteed it. It's the hand on the doorknob moment of, oh wait. But that'll just mean we have to do another episode on it.
Yep.
That's right. Well, very good. Well, this was a really cool episode. Hopefully those are some helpful tips for our listeners. So to our audience, thanks for listening, and tune in next week for more. Be sure to subscribe and leave a review in iTunes. We'd love to hear from you. You can also follow us on Instagram, Facebook, send us some ideas for our book coming up about IVF next year. We're in the middle of writing it now. So we'd love to hear from you.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously in our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to y'all soon. Bye.
Bye. Bye.